My name is Sarah Abusi, and an internal medicine resident, and today I'm presenting a case of cerebral myelopathy, a rare but clinically important cause of acute non-traumatic spinal cord injury. Cerebral myelopathy most commonly affects first-time surfers, and it's thought to result from prolonged prone positioning with repeated spinal hyperextension during paddling. This posture can transiently compromise blood flow to the thoracolumbar spinal cord, producing ischemic injury without a structural lesion. The challenge is that its presentation overlaps with other neurologic emergencies, such as spinal cord infarction, compression, inflammatory myelitis, and vascular malformation, each requiring different management. Our patient was a previously healthy 30-year-old male who developed sudden bilateral lower extremity weakness and sensory loss approximately 1 hour into his first surfing lesson without trauma. On examination, he was hemodynamically stable. Neurologic exam revealed severe weakness in both lower extremities with preserved upper extremity strength. Sensation to light touch and temperature was reduced below the knees, while vibration sense remained intact. Reflexes were symmetric and pathologic reflexes were absent. He also had acute urinary retention, suggesting spinal cord involvement rather than peripheral neuropathy. A broad workup was initiated. Lab studies and cerebrospinal fluid analysis were unremarkable, making infectious, inflammatory, and autoimmune causes less likely. MRI of the spine demonstrated longitudinal T2 hyperintensity with cord expansion extending from lower thoracic spine to the conus medullaris, concerning for ischemic injury. Because MRI cannot reliably exclude vascular pathology, spinal angiography was performed and showed no evidence of AV malformation or flow-limiting lesion. The absence of compressive pathology, demyelination, or vascular abnormality, combined with the characteristic imaging finding and the clinical context of prolonged spinal hyperextension, supported the diagnosis of cerebral myelopathy. The neurologic pattern suggested involvement of corticospinal and spinothalamic tract with relative sparing of the dorsal columns, consistent with anterior spinal cord ischemia. The patient was treated with high-dose intravenous corticosteroids for 5 days, with significant improvement in the lower extremity strength. Repeat MRI demonstrated near complete resolution of the spinal cord signal abnormality. Urinary retention gradually improved, allowing transition to intermittent catheterization, and the patient was discharged to inpatient rehabilitation for continued recovery. This case underscores that sudden bilateral lower extremity weakness without trauma represents a neurologic emergency with a broad differential diagnosis. Cerebral myelopathy should be considered in young, healthy patients presenting after activities involving sustained spinal hyperextension not limited to surfing alone. While MRI is essential for initial evaluation, spinal angiography plays a critical role in excluding vascular lesions that may require emergent intervention. Prognosis is closely linked to the severity of neurologic deficit at presentation, and early recognition and prompt supportive care rehabilitation can significantly improve outcomes. In summary, cerebral myelopathy is a rare but potentially reversible cause of acute myelopathy, and heightened clinical awareness is key to prevent long-term neurologic disability. Thank you.